Okay. All right, we're going to go ahead and get started. Welcome, my name is Heather Swindle, and I am the system educator for the emergency departments for St. Vincent's. East has always been my home. I've started out here, but I've been with St. Vincent's for 25 years. Most of that has, all but my first 2 years has been in the emergency department. So today's topic, we're going to talk about adult codes. We're going to look at our drugs that we use with our adult codes, and it's going to be based on American Heart Association guidelines for advanced cardiac life support. We're going to look at our potential resuscitation drugs and drips that we used in our adult codes and talk through our pharmacy practice management of those medications based on best practice evidence-based research, and talk about some pharmacy-specific, ER-specific medication ordering processes. When we're approaching our resuscitation patients, we do use American Heart Association guidelines. Y'all know that every 5 years American Heart does research and takes what works good with resuscitation, what can be improved, and that's where we get our guidelines for our care. So we are on the 2015 guidelines that are published by the American Heart. We will get more guideline changes in 2020, but for now what we are using are the 2015 guidelines. The course that most of our drugs are based on come from Advanced Cardiac Life Support. This is a 2-year certification course that all the nurses in the ED are required to have, as well as the ED physicians. But it does guide our care and especially our medications used for adult arrest. What the ACLS course does is organize the care into algorithms for a quick reference for rapid intervention of how to approach different arrest events. And the algorithms are designed on either the rhythm, the presenting rhythm of the patient, or even the clinical condition. So there are algorithms for bradycardia, tachycardia with a pulse, cardiac arrest. There are also algorithms for acute coronary syndromes, which would be our chest pain patients and stroke patients. Today we're just going to look at those rhythm algorithms. This algorithm that we're looking at now is kind of the all-encompassing algorithm. It gives you a good picture of what should be taking place during our adult resuscitations. You'll notice that that circular portion of the picture says continuous CPR. We can talk about drug therapy and we can talk about electrical therapy with advanced life support, but unless we're doing our good BLS skills and getting those compressions, keeping those ongoing, it's not going to matter. So that's why that circular kind of encompasses drug therapy, advanced airway and reversible causes, because we can do all that, but if we're not doing our compressions effectively, it's not going to help our situation. Your objectives when you're thinking about code medications and adjunctive therapies, you want to correct any hypoxia that we're seeing. You want to restore circulation and get adequate blood pressure. You want to promote good cardiac functioning. You want to suppress any arrhythmias. We are going to attempt to relieve pain, correct electrolyte imbalances, correct acidosis, any other drugs that we've identified that could be like overdoses, we would help to correct those and treat heart failure if that's also identified. The first algorithm we'll look at is too slow. We're going to look at bradycardia. This is our algorithm for bradycardia, and what you'll notice, the way the algorithms are designed, it's a step-by-step approach, kind of you see this, you do that, what if this, then do that. And that's how we approach our care when our patient comes in. So when we look at the bradycardia algorithm, we're looking for typically a heart rate less than 50 to start to guide our care. Any of the medicines that we have to give with these patients, they're going to be listed in those gray boxes on the right-hand side of the algorithm, and it'll tell you where to start and ranges to give with your drugs. Rhythms that are bradycardic, you have sinus brady, which is the strip on the left. You also have second-degree heart block. This is a type 1. There is also a second-degree heart block type 2 and a third-degree or a complete heart block. Any of these rhythms would be considered bradycardic, too slow, and they would apply to the bradycardia algorithm. What we typically look at is a heart rate less than 50, but also how symptomatic is the patient. We get plenty of folks that come through our facility that might have a low heart rate, but that could be their normal. You got a conditioned athlete, they're going to run a lower heart rate. You get folks that are on a lot of cardiac meds, they're going to have a lower heart rate just to preserve heart functioning. So really you have to take the whole clinical picture into account. What symptoms are they displaying with their low heart rate? And then we would act on that. Some of the symptoms we might see are poor perfusion, like with they may have an altered mental status, they may have chest pain, are they having an acute MI, are they hypotensive, are they in shock, could it be sepsis? So those are some of the presentations that we look at. If they have a low heart rate, it's not their normal, but they're not symptomatic. It's kind of where we observe, monitor, watch, and wait. We might draw labs. We might do 12-lead EKG, do some other investigative work to figure out the why of your low heart rate. But if they are symptomatic, then we follow our algorithm and we start to treat the patient. You'll notice the first treatment that's on here is oxygen. Pretty much hypoxia and bradycardia will go hand in hand. One of the first things that we see as people get hypoxic is they'll start to slow with their heart rate. So we're always thinking about airway and breathing and making sure that we've got oxygen on our patient. We would also start to prepare for transcutaneous pacing. Especially if we see a second degree or a third degree block, because that can be very, very life-threatening. Folks that come in with those blocks are extremely sick, and you're at risk for losing your heart rate altogether. The first drug that we would give for bradycardia, though, is going to be Atropine. 0.5 milligrams IV. We'll do a dose of that while we're getting a pacemaker in place. You can repeat 0.5 milligrams up to 1 milligram every 3 to 5 minutes. No more than 3 milligrams, though, total on your Atropine. If Atropine is not effective, if we're not getting anywhere after our 3 milligram max, then we would put the pacer on a patient. Now this poses a little bit of a problem if the patient is alert and oriented. When we pace somebody transcutaneously, we're actually putting the defibrillation pads on their chest and setting the machine to deliver a shock to make the heart beat. So there's not a lot of tolerance there. People just don't tend to tolerate that, because if it's about like me telling you to hold your finger in the light socket. It's going to shock you every few seconds to make your heart beat. Now certainly if the patient's unresponsive, it's a fairly viable option until we can get a cath team in to do a pacemaker. But pacing while they're awake, again, we just don't get a lot of folks that can tolerate that. A better option would be to consider an infusion. Generally an Epi Drip or a Dopamine drip can be used to help with the bradycardia. Your epinephrine drip dose is going to be 2 to 10 mics per minute. Your dopamine dose would be 2 to 20 mics per kilo per minute. For 2015, the dopamine dose range did change. On the old guidelines, the max was 10 on the dopamine, but they did increase that to 20 mics per kilo per minute. Then we would prepare the patient for a transvenous pacer if we saw that that was necessary. This would be involving the cath lab, where they actually have to go and insert a pacemaker for the patient. But one of the things that we do is we do think about the whys, the reversible causes, the things that can be contributing factors. Certainly people lose the natural ability of the heart to pace and beat itself, and that is the person that would have to go for a transvenous pacer. But there are plenty of instances where we can figure out why you're having an issue. For example, a beta blocker overdose. We get some elderly folks that'll come in, they'll wake up in the morning, take their heart pill, and then an hour later, did I take my heart pill? Let me take my heart pill. And before you know it, their heart rate's too low because they've overdosed themselves accidentally with their heart medicine. Electrolyte imbalances can also cause some bradycardia, so we usually investigate that as well. With your atropine, your mechanism of action, it does have parasympathetic action. It blocks the vagus nerve to increase the heart rate. Again, we give it for a heart rate less than 50 when folks are symptomatic. Your dose again being 0.5 milligrams IV up to a max of 3 milligrams. Your pharmacodynamics, the onset of action is immediate with a max effect in 0.7 to 4 minutes. Half-life elimination is really age dependent. It is excreted through the urine. We do have to use a little bit of caution when we give it with folks that we see that are having some block because it can backfire a little bit and cause them to go into ventricular fibrillation. We also are very cautious with it with folks that are having an MI because it will increase myocardial oxygen consumption, and you don't want to do that in the presence of an MI. If we're using dopamine for bradycardia, it is an adrenergic agonist, an inotrope, and it will increase the contractility of the heart, so it's a good medication to get things moving with a heart rate. Causes a lot of arterial and venous constriction. The onset's within 5 minutes, a duration of less than 10, half-life is approximately 2 minutes, and this one's excreted through the urine as well. For dopamine, we only give it IV. It is a drip, your concentration being 400 and 250, or an 800 milligram in 250, and generally the 2 to 20 mic per kilo per minute range is what we do. It is very caustic to the vein, so we do want to make sure we've got a dedicated line because if it infiltrates, it can cause a lot of problems for the patient. If we decided on the epinephrine drip, it does stimulate your alpha and beta responses. It will cause that cardiac stimulation to get the contractility going of the heart again, to get the heart rate up. Your onset of action is within 5 minutes, half-life elimination is less than 5 minutes, and excreted through the urine. Your dose for your epi should be 1 milligram in 250 for a 4 mics per milliliter on your drip, or a 4 milligram in 250 for 16 mics per ml. We do this infusion rate at 2 to 10 mics a minute or at 0.1 mic per kilo per minute. It is also caustic to the vein, so again, a good dedicated IV is what you want. So what about rhythms that are too fast? Your tachycardia algorithm, this one, the patient still has a pulse. So may not have a great pulse, it may be a weak and thready pulse, but the tachycardia algorithm, the patient generally is still fairly alert and has a pulse with that. And again, you'll see a systematic approach. If you see this, then you move to that. Ask your lots of why questions. And our drugs, again, are over on the right-hand side in the gray box. So tachycardia rhythms, generally with this use of this algorithm, you're looking at 2 types of rhythm, either narrow complex tachycardia or wide complex tachycardia. We differentiate that by measuring out that QRS, which is kind of the V portion of the rhythm. But we're looking at a heart rate greater than 150. They are symptomatic with their heart rate that's fast. We're looking at the QRS that's greater than 0.12 seconds when you measure it out. And your screen there shows you the differences between wide, narrow, and normal. So for your narrow complex tachycardia, the first thing we'll get the patient to do is vagal. If we can simulate them vagaling, have them hold their breath and bear down a little bit, sometimes it'll slow their heart rate down. We even have some physicians that'll come in and do a carotid massage, and sometimes that can vagal the patient. It may slow them down for just a minute. If that does not work, then we can start with our drugs, and our first drug of choice here is going to be adenosine. 6 milligrams, we give that very rapid IV push, and it's followed by a 10 cc flush. You want to give it very rapidly. If that is ineffective, then you can double your dose and give 12 milligrams of adenosine very rapidly, followed by the push. The adenosine is really meant to reset the electrical programming of the heart. If I took our computer right here and hit Control-Alt-Delete to restart the computer, it's the same thing my adenosine would be doing for that electrical conduction cycle in the heart, to try to attempt to restart it and reset itself to cure the tachycardia. If it persists, if your adenosine doesn't work, then you're kind of thinking more beta blocker, or you're thinking calcium channel blocker. Typically the rate when it's so fast is really masking an underlying rhythm. So when you give your adenosine, if it doesn't break the rhythm, it will, however, slow it down long enough for you to look and see what the underlying rhythm is. A lot of times what we see is it's an atrial fib underneath, or you may see an acute MI underneath that you couldn't see otherwise because the rate was too fast. So that will really guide whether you're choosing beta blocker or calcium channel blocker. When we say atrial fib, we tend to use Cardizem or calcium channel blocker of choice there. Beta blocker, if we go that route, typically low pressor, 5 milligrams IV push every 5 minutes times 3 doses is what we'll do. We're very cautious with that one because it will lower the blood pressure significantly, and a lot of times it will lower the blood pressure before it really gets too much of your tachycardia down. If all else fails, if we've tried our drugs, tried some infusions, even switched to Cardizem or beta blocker, and that's ineffective, when the patient becomes unstable, if they're hemodynamically unstable, then we synchronize cardiovert. And that's where we put defibrillation pads on the chest, set the defibrillator. We use a special button to synchronize with what beats the patient is doing with their heart, and we actually give electrical therapy to get them converted. Now, if it's a wide complex tachycardia, you can consider adenosine if the rhythm that you're seeing is monomorphic and regular. Mono means one, morphic is shape. So the rhythm that you're seeing there on the left, that is wide complex tachycardia that we would consider one shape. In other words, it's not varying across your screen as you're looking at it. It's all the same. So I could try adenosine with that particular rhythm. However, the rhythm that you see on the right is polymorphic. You'll notice it has many shapes. That's what we call torsades, and that is not one that we would use adenosine with. Really, for the wide complex tachycardia, your better choice is going to be amiodarone. This is where we give 150 milligrams over 10 minutes. If that's not effective, it's not helping with our heart rate, then we would consider our cardioversion. And if at any time the patient becomes unstable, we would cardioverse them. So for your adenosine, your mechanism of action, it does slow that conduction through the AV node. It'll interrupt the re-entry pathways to try to restore the heart back to the normal intrinsic sinus rhythm. Your indications being a heart rate greater than 150 and your patient's symptomatic with it. Your dose again, 6 milligrams rapid IV push, followed by that flush of 10 cc's, and a second dose of 12 milligrams IV push, followed by a flush. Your onset of action is really, really rapid. When we give adenosine to patients, we really want to prepare them because we're going to put them in asystole for a few seconds. But almost as quick as we push the drug, you'll start to see the heart rate come back up. So the duration for it is extremely brief. It wears off almost as quick as we can get it in. Half-life is less than 10 seconds. We do proceed very cautiously if we see first-degree block or a bundle branch block with this particular use of drug because it can put them into VFib. And again, we don't use it with our polymorphic wide complex tachycardias. We'll look at amiodarone again. There are 2 ways to give amiodarone based on our algorithms. We just explored wide complex tachycardia with a pulse, but we'll talk about amiodarone in use with our cardiac arrest as well. So let's talk about pulseless arrest. So this is our patient that's come in as a full arrest, no pulse. We're actively doing CPR on them, or maybe they've been here and progressed to an arrest state. This is our pulseless arrest algorithm. Again, you'll notice top right-hand side, it really re-emphasizes good CPR quality because when we're giving drugs, if we're not doing good compressions and good CPR, our drugs really aren't getting circulated anywhere. When you look at this algorithm, there's really 2 roads to travel. Left-hand side being shockable rhythms. Really get a little bit more chance of success with shockable rhythms than we do the right-hand side, which is your asystole and PEA. So once we have the patient that's in arrest, our first actions, other than getting those compressions continuous, would be to get our monitor applied so we can determine what rhythm they're in and then which road we need to travel on our algorithm. So our rhythms that we look at, shockable, on the left-hand side there, VFib, ventricular fibrillation, or ventricular tachycardia. And if you look at that ventricular tachycardia and you're like, you know, that one looked just like the wide complex tachycardia, you're correct. When folks have a wide complex tachycardia, I always teach the staff to say two things to yourself. Is the patient talking to me, and do they have a pulse? If they're talking to you and they have a pulse, then that's wide complex tachycardia, and it's the algorithm we were on just a minute ago, tachycardia with a pulse. If the patient has a rhythm that looks like that, but they're not talking to you and they don't have a pulse, then you're on the Pulseless Arrest algorithm. So the rhythm will look the same, but based on patient's responsiveness and pulse, treated differently. Your non-shockable rhythms, of course, your asystole, and then your PEA, which is pulseless electrical activity. In other words, our monitor is picking up all of that electrical activity of the heart, but it's not causing the heart to beat. So when we see that on the surface, you look at your rhythm and you think, well, the patient's in a good rhythm. You've always got to make sure you put your hands on the pulse. You want to palpate for a good viable pulse with that rhythm. If you can't feel it, you even want to get a Doppler to see if it can be picked up by Doppler. But if we see that and there's no pulse, then we're going to be doing our CPR. So that's why it's very important. Got to make sure that we've got our compressions going in our pulseless arrest, whether it's the shockable or non-shockable rhythms. When we're giving drugs during our pulseless arrest, it's very important to be organized. You want to make sure that we get drugs prepared and ready to go before the time of the next rhythm check, which we only stop and interrupt compressions every 2 minutes to check to see what the rhythm is. Otherwise, compressions should be ongoing. When we give our drugs, we need to give them during that compression cycle. So you're going to stop only long enough to check the rhythm, apply defibrillation if needed, and when you're administering drugs, we're making sure that we do so with compressions that are ongoing. Your pulseless arrest, drugs that will incorporate oxygen. Anytime folks are pulseless and we're doing our CPR, we've got our bag mask device going. We're even preparing to intubate them, put them on a ventilator. Our pressor agents, VTAC, VFibs, PEA or asystole, our drug of choice throughout either of those events are going to be epinephrine. Some targeted antiarrhythmics we would use would be amiodarone, lidocaine, and magnesium. Oxygen, really want to make sure that we've got effective oxygenation going on because it'll elevate your arterial oxygen content, it'll improve your tissue oxygenation. We use it for chest pain, we use it when the patient's hypoxic. It is a mainstay throughout our cardiopulmonary arrest. Epinephrine has alpha and beta receptor agonists. It'll cause your increase in coronary perfusion, cerebral perfusion and pressure. It will increase cardiac oxygen demand. So in an MI that has arrested, we still do use it. We want to get a pulse back so we can get them to a cath lab to effectively treat them. But our whole goal in using epinephrine is to get ROSC. ROSC stands for return of spontaneous circulation. So our whole goal here is to get the pulse back, get the patient spontaneously circulating on their own. We give the epinephrine for any of our rhythms, VTAC, VFib, asystole, or PEA. We are cautious in the presence of myocardial oxygen demand, but again, we wouldn't withhold it. And we do want to avoid mixing it with alkaline solutions. Your dose for your epinephrine, it does come in our pre-filled cartridges, 1 milligram. We'll give it IV or IO. An IO is an intraosseous use of route of giving drugs. It is a large needle that bores into the bone marrow space. Anything that you give IV, you can give IO. The preferred place for our adult patients is going to be the humeral head. We actually have a drill that's pretty foolproof that we can get that needle in place very quickly. Some of our folks come in and just don't have good veins, just don't have good access. So if we're having problems getting access, we're pretty quick to put an IO in. You can also give epinephrine down the ET tube. So if we've gotten them intubated but we're still having trouble with peripheral access, we can give epinephrine down the tube. However, we do double our dose, 2 to 2.5 milligrams, diluted with a little bit of saline down the tube. And we repeat our epinephrine every 3 to 5 minutes. We don't generally give a dose greater than 1 milligram at a time. In guidelines past, there was high-dose Epi that was recommended, but that's no longer a recommendation. You also want to consider your antiarrhythmics. If you've given a first dose of vasopressor and you're still in a persistent VTach or VFib rhythm that's kind of refractory to any shocks, you want to consider giving amiodarone. It's your preferred antiarrhythmic, especially for your VTach, VFib that haven't been converted. Remember we talked about it with the wide complex tachycardia, and in that instance when the patient has the pulse, you're going to give it 150 milligrams over 10 minutes. But in the pulseless arrest state, you're going to give 300 milligrams IV push. So there are two very different ways that we administer the amiodarone, pulse versus no pulse. We have to make sure that we know our differences. So in the pulseless arrest, if we've given 300 milligrams push and they still remain in a persistent VTach or VFib, we can give an additional 150 push, but our bolus would never exceed 450 milligrams. If the patient does convert and we've used amiodarone, that's typically when we're requesting the amiodarone protocol from you guys, where we do that 360 milligrams over 6 hours and then 540 milligrams over the next 18 for a total of 24 hours coverage with amiodarone. One thing I have told the ER staff when they're filling out their request for the drug is to let you guys know if we've already done the bolus. Because I know when y'all send the protocol, y'all typically send us the bolus and the drip. So we want to be mindful of not being wasteful. So we want to make sure that let y'all know if we've already done the bolus. Lidocaine is also an antiarrhythmic that we can use. In years past, this was really our mainstay before amiodarone hit the scene. And then somehow amiodarone became a little bit more the superior drug. I'll tell you, in 2015, when the PALS algorithms came out, lidocaine is now on the algorithms for use with VTach or VFib. Now, it is not on the adult algorithms, but it is on the PALS algorithms. And it's a choice of amiodarone or lidocaine. And about 9 months ago, American Heart did send out a revision to guidelines that said you could also now incorporate lidocaine as a choice in your adults. So even though you won't see it on those algorithms that are in your packet, the original 2015 algorithms for pulseless arrest, it is a new recommendation from American Heart. So if we decide to use lidocaine, generally we're using it if amiodarone were not readily available. But again, it should be one course or the other. You're either doing the amiodarone course or you're doing the lidocaine course, one or the other. We'll give a bolus at 1 to 1.5 milligrams per kilogram. And you can repeat that at 0.5 to 0.75 milligrams per kilo with a max of 3 milligrams. And then you would start an infusion, 1 to 4 milligrams a minute on your lidocaine. Magnesium, another drug that we might give. It does act as a calcium channel blocker, helps to decrease that ventricular rhythm. Torsades is the rhythm that we typically will use our magnesium for. So that polymorphic rhythm that we looked at a minute ago, when we see that, we usually know that the patient has some type of magnesium deficiency. Our biggest awareness here are folks that are potentially alcoholics going into withdrawals. You will see this rhythm a lot. They will go in and out of torsades quite a bit. So we usually try to head that off on the front end and check a magnesium as soon as we know that there could be an issue. But if we see the torsades, then we generally give magnesium. Other conditions that might be associated with malnutrition where there's the potential for the magnesium to be off is also where we would give that. And we've decided to freeze up. There we go. So our mag dose, 1 to 2 grams IV or IO. Again, we don't just automatically give magnesium. We would have to have an indication. We'd either see the torsades or know that we have a history or a lab value that shows a magnesium is altered. So again, it's not a routine administration. It is only if we have an indication. If we were presented with asystole or PEA in our arrest patient, Really only 3 things to do for that. High quality CPR, give some epinephrine, and try to find the why of why they arrested. Get to a reversible cause. So again, epidose is the same for asystole and PEA, a milligram IV or IO every 3 to 5 minutes. And then we want to think about those contributing factors. In other words, what do we think made the patient arrest? Those have always been devised in what we call our H's and T's, those common things that make people code that we can potentially reverse. Hypovolemia, is the patient a trauma? Are they a GI bleed? Have they had some persistent dehydration issues? In that instance, we're either going to give fluids or blood to reverse them. If they're hypoxic, we can intubate them, we can give them oxygen. If they're a hydrogen ion deficiency, that's acidosis. We can give bicarb to correct that. If there's a potassium problem, we would adjust medications to fix potassium. If it were hypoglycemia, we'd be checking the blood sugar on them, getting some dextrose on board. If they're hypothermic, we're going to try to get them warmed up. We can use warm fluids, warm lights, warm blankets to get the core temp up. Your toxins, biggest offender is going to be your opioids, your narcotics. We can give Narcan for that. We get a lot of folks that do benzodiazepine overdose, give our Ramazicon there. Otherwise, we're kind of at the mercy of collecting a good history. You know, what was in the patient's possession, what could they potentially have gotten a hold of, what was laying around them when they were found. I've got probably 25 years worth of stories of things that people that try to overdose on that would amaze you. Clorox, Pine Sol. I had one patient that worked at a veterinarian's office that drank flea dip. Not the little front line that goes on the back of their neck, but I'm talking about flea dip, like you put your bird dog in. And it's an organophosphate, and we wound up in hazmat suits with that person. So again, getting a good history of what potentially could they get into. Then we usually communicate with poison control, and they'll tell us what we could do to help reverse it. Your next one's on there, tamponade, tension pneumo, thrombosis, trauma. Any of those you can get from a trauma-related event. A cardiac tamponade, you can get that from an endocarditis or a myocarditis that progresses. Thrombosis, coronary, that's your acute MI. That's someone that's got a clot in their coronary artery. But again, we would want to identify those and try to treat those causes. Other drugs we might use in our code, calcium chloride or sodium bicarbonate. Again, either of those, you really want an indication before you give them. We don't typically just give them as a last-ditch effort. We would really want to see an indication for giving those. If we gave the calcium chloride, it increases the cardiac contractility. It's effective at counteracting some proarrhythmic problems, potassium problems. So if they're hyperkalemic, hypocalcemic, if they have had a calcium channel blocker overdose, it can potentially reverse that. Your dose is 8 to 16 milligrams per kilogram in a 10% solution that can be repeated in 10 minutes. We do precautiously watch for bradycardia, because if you give it too fast, it can lower the heart rate too much. A lot of cautions used if they're on DIG. With our digitized patients, we don't tend to do that one as much. And it will precipitate if we give it with bicarb, so we make sure that we don't do that. Your sodium bicarb, some of the indications, if we know they have a high potassium, we may give some bicarb. If they have a known pre-existing bicarb responsive state, if they're acidotic. If they've been down quite a long time, we might use some bicarb, but we'd have to know, sometimes we don't know the time that they arrested, but if it's been a prolonged arrest period, we might use it. But again, it shouldn't be within our priorities. Our priorities should be to intubate, to ventilate, defibrillate if indicated, and give our epinephrine and antiarrhythmics before we would consider giving the bicarb. It's 1 milliequivalent per kilogram given IV. It's worsened mixed venous acidosis with CO2 and retention. That's a precautionary that we would think through. If you've got metabolic alkalosis, you definitely would want to think through that. And again, we need an indication before we give it. We just don't routinely give it. I also put a couple of little snippets in here about communication between the ER and the pharmacy. I know that with one chart, there are items you guys have to have to get drugs to us. But when we do have folks that come in as an arrest, from the nursing standpoint, we document on paper. So we may, other than the quick registration that takes place, this patient may not even be placed in one chart initially. And I know that that can be very problematic because you got us calling you on the phone, I need this, this, and this, and you have to have whatever in the computer there so that you can dispense the drugs to us. So it's definitely difficult on both ends. So what we have asked the ER staff for is when they call you, at bare minimum, they should have a name, a birthday, allergies, and an estimated weight. Because I know those are kind of the must-haves for you to dispense whatever. Now that's if we know it. We do get Jane Doe, John Doe in every now and then. You know, you might get somebody that's just been dumped in the front of the hospital. You never know. But when we can, we should at bare minimum give you those items so that you can effectively do what you need to on your end to get us the medication. Now once the patient is stabilized, you should start to see orders in one chart. The physician will be putting orders in. Now keep in mind it might be retro. So it might be 30, 40 minutes after the fact once the patient's stabilized. But when we can, they will start to order those medications in the computer. Now they don't always go back and put the medicines in that we've pushed. Like if we did an epinephrine every 3 to 5 minutes IV push, they may not put those in, but any of those drips or those items that we're requesting from you, they will go back in and put. Because I know profiling down the road for when the patient's admitted, those medicines are very important to have in. So pretty much that order set that's the Titratable Drips, that's one that we would utilize a good bit if they're going to order an Epi Drip, if they're going to order Levofed, Dopamine. They would utilize this particular order set when they're requesting the medicine from you. And if we were doing the Amiodarone route, we would be using that Amiodarone order set. Again, the one thing that I try to stress to them is make sure that we have unchecked that bolus. If we've given the bolus, my doc should uncheck that bolus request from you. That way we're not getting a medicine that we've already given, so we're not wasteful. What questions do y'all have? And certainly I'd love to open up dialogue for things that you think on your end that we could improve from the ER standpoint, because I very much